Well, hello. We're going to do now Chapter 5, which is on the integumentary system. If you're not familiar with that term, that really refers to just basically the skin. But we're going to get into the skin and its accessory structures, such as hair, nail, etc. So let's get started. When we look at the integumentary system, it consists of skin and various accessory structures. These include, of course, the sweat glands, the sebaceous glands, the sensory organs such as the Meissner's corpuscle and Pacinian corpuscle, and the hair shafts. When we look at the structure of the skin, it is been referred to as a cutaneous membrane. The outermost layer, which faces the dry air environment, is the epidermis. Beneath the epidermis is the dermis, which can be divided into a papillary layer. That's the layer basically between the blood vessel plexus, called the subpapillary plexus, and the dermal papillae. That's those little bumpy structures, and you see there are little clusters of blood vessels there. These are little capillary beds in the bumps, and they feed by diffusion nutrients over to the underlying layer of the epidermis. But we'll get more into that later. The lower layers are referred to as the reticular layer. So the reticular layer basically goes between the subpapillary plexus and basically the subcutaneous plexus, which would be down over here. Below this is really the hypodermis, which consists of areolar tissue and adipose tissue. You want to also be mindful that certain structures have nerve innervations, such as the hair follicle, and we have nerves there, nerve fibers here, nerve fibers here. Some of the nerve fibers reach up to the tactile corpuscle, the Meissner's corpuscle. You also have this sebaceous gland, which produces sort of the oil, which helps lubricate and keep somewhat moistened the hair shaft. Okay. Also, this entire follicle can be pulled sort of straight upwards by this small tuft of smooth muscles here called the erector pili muscle. Of course, you will also notice down throughout here, artery and vein here. You'll also note the sweat gland, which will empty out onto the skin, okay? And from there, we'll get into some of the structures. As you can see, I've mentioned this before, the cutaneous membrane, which is divided up into epidermis, dermis. The subcutaneous membrane, hypodermis, which separates the integument from the deeper organ fascia. Accessory structures that we're going to spend time on are the hair shaft, and those structures around the hair shaft include the erector pili muscle, the hair follicle, sebaceous glands. We also have to deal with the sweat glands and the lamellar, otherwise known as Pacinian corpuscle. We have mentioned earlier nerve fibers and also the network servicing the tissues of the integument called the cutaneous plexus. That's where I was corrected before, which is basically at the boundary between the dermis and the hypodermis. That's one network of a larger artery and vein, and then a smaller set of artery and vein network is the subpapillary plexus, which is sort of the boundary between the papillary dermis and the reticular dermis. The functions of the integumentary system: basically to protect underlying tissues and organs against impact, abrasion, fluid loss, chemical attack. There is excretion of salts, water, organic waste by the integumentary glands. They maintain the body temperature through either insulation or evaporative cooling as needed. You also have the production of melanin, which prevents or protects the underlying tissue from ultraviolet radiation. The layers also produce keratin, which protects against abrasion and serves as a water repellent. Now in the skin, we also synthesize vitamin D3. It's a steroid that is subsequently converted to calcitriol, a hormone important in the normal calcium metabolism. In this area also we can store lipids and adipocytes in the dermis and in the adipose tissue in the subcutaneous layer. That's also referred to as the hypodermis. We also can detect touch, pressure, pain, temperature stimuli, and relay that information to the nervous system. You notice here's the epidermis, and wherever there is a ridge, that's usually at the trough here of the dermal papillae. You notice the coloring here at the very bottom of the dermis. That's the area that really germinates new cells, and they basically push up the other layers of cells. Here you can see all 5 layers of the epidermis. This is what you normally would see in thick skin. In thin skin, I want you to be aware of this. The striatum corneum is going to be less, and there will not be a layer of striatum lucidum. Starting from the beginning, the striatum basilae, also it's called striatum genitivum, this is the area that basically undergoes mitosis to generate new cells. These cells will go through morphological and biochemical changes as they move upwards. This is where you're going to get the stratified epithelial cells, but eventually what happens is by the time you get to about the latter part of the striatum granulosum, or in some cases the striatum lucidum, definitely by the time you get into the striatum corneum, all these cells are dead. So you see all these layers here in the striatum corneum, they're all dead. They're just used to prevent against abrasion, water loss, etc. So the striatum basilae is there. The next layer up is striatum spinosum. Then you get to striatum granulosum here. And then the striatum lucidum. Lucidum is only like 4 or 5 cell layers thick. It's almost clear, okay? And then, of course, the corneum here, which really is loaded up with keratin, both externally from the cells, but also internally in what is now basically just cell membranes. There's no real organs, there's no biochemistry, there's no chemical reactions, no metabolism going on at the time, okay? Down here, be mindful of the fact that you're going to have little tufts of capillaries. These in the dermal papillae will actually, by diffusion, feed the nutrient requirements of these actively mitotic cells down here in the striatum basilae. Notice the difference in the layers and thickness here of the thin skin for the epidermis versus the epidermis here in the thick skin. Both of these are at the same light microscopic magnification of 225. But you can see the definite difference in the number of cells, and then particularly in the striatum corneum. Much, much less here, much, much more here. Okay? Now, as we go into terminologies, I want you to be aware of some other cells and some other structures here. The key point is that the epidermis is absolutely important in the protection of the body from infection. It's the boundary. It's one of what they call the mechanical basic protections or barriers, mechanical barriers against infection. And this is in part due to the protein called keratin, which is an insoluble protein. Now, also we have the procedure of perspiration. There's 2 types. Insensible, this is unable to see or feel. It's produced by interstitial fluid loss. But then the sensible stuff, on a hot day, you would notice it. You'd be starting to perspire. This is produced by active sweat glands. Also, in the lowermost levels of the epidermis, you're going to find what are called dendritic cells. Otherwise, they go by the name Langerhans cells. They are located in the striatum spinosum, in here, and they act to participate in immune defense for microbes and surface cancers. Okay. fingerprint patterns. How do we get them? Well, they're caused by ridge patterns in the thick skin of the fingers. It's interesting to know that in between these, and you can see some of the little points or divots here, you're going to see sweat glands between the ridges. This is determined by genes and intrauterine environment during fetal development. We all have different fingerprints. And the interesting thing here is that as you basically leave a fingerprint somewhere, you're leaving an imprint in part developed by some of the sweat glands, moisture. But it's interesting because this is, of course, you're familiar that forensic science uses for identification of someone. Well, in 1999, the interesting thing that was developed at Quantico, the FBI Research Center, is they were able to extract DNA from the fingerprint to be able to use that in the definite identification of a suspect. So not only do you get the physical fingerprint, but you're able to get the actual DNA fingerprint of the individual who left the fingerprint behind. Now, here's a better image, and I wanted to go over this with you for a minute. Here's the papillae of the dermis. Here is the active mitotic center, the deepest epidermal layer called the striatum basale. It's only about a layer or two thick. You have stem cells here. They undergo mitosis. The cells develop further and are pushed upward. The next layer is striatum spinosum, several layers of keratinocytes, but they're unified. They're held together by desmosomes. The cells contain thick bundles of intermediate filaments that are made of pre-keratin. Then we go up to the striatum granulosum, which these are 3 to 5 layers thick. They're flattened. Cells have begun to basically deteriorate. The organelles are deteriorating. The cytoplasm is full of laminated granules that release lipids and keratohyalin granules. That's what we call it, a granulosum. Then we get up into the striatum corneum. Now, in there's a striatum lucidum for the most part. At the lucidum level, they're pretty much, the cells are dead. The striatum corneum is the most superficial layer. 20 to 30 layers of dead cells, represented by flat membranous sacs filled with keratin. There are some glycolipids in the extracellular space. Now, a couple of things. How do I get a difference between thick and thin? Wherever there's a lot of pressure. So, palms of the hands, to a degree. You see what calluses are. Soles of the feet. Okay. These are the places you would have a lot of thickening of the skin, and that would be the place that you could see a great quantity of striatum corneum. But if you take a look at, say, your shoulder, your face, your belly, your buttocks, these would all be thin-skinned areas, okay? Also, as I mentioned before, the epidermal dendritic cell, which acts in here as sort of an immune modulator or immune monitor, I should say, which is activated further if there's presence of bacteria, etc. The Merkel cell is in detection of certain types of physical pressure, followed and transmits information back through the sensory nerve ending. You also have melanocytes. Now, melanocytes are cells that produce melanin. Melanin is basically like a polymer of tyrosines, which are amino acid. But what they end up doing is they absorb ultraviolet light. Melanocytes can transfer some of their granules to other cells, such as these fibrocytes here. But I want you to be aware of also something else. If you notice, there's sort of cytoplasmic extensions from the melanocyte, and they stretch out and wiggle and worm through some of the areas of spaces between these other cells. These account for the different pigmentations that you would see in the skin. Okay, and here are the layers again. I encourage you to review them and get to know them very well. Well, as I mentioned before, the striatum lucidum, the clear layer, it's only present in thick skin layers. It separates the striatum corneum from the deeper layers. Cells are densely packed, flattened, lack organelles, filled with keratin and keratohyalin. Basically consist of striatum granulosum cells that have died. Melanin. As I mentioned to you, it's a polymer of tyrosine, which is an amino acid. And this is done by a particular enzyme called tyrosinase. Melanin can account for the colors of yellow, brown, black pigments. It's basically just an amount, and this is partly determined by genes. The melanin granules are transported by melanosomes into intact keratinocytes. Are there other pigmentations you might see? Yes. Carotene. This is the pigment that you see, the counts for the oranges and yellows you see in squash or oranges, etc. Carrots. They accumulate in the striatum corneum, in the deep dermis, and in the fatty hypodermis tissues. What about freckles and pigmented moles? These are concentrations of melanosomes. Ultraviolet light, particularly in the higher frequencies, leads to increased pigmentation. This is really just a radiation response tan. Okay, I'll give you a little backstory on this. Turn of the century, we had one of these jet setters that was known as Coco Chanel, and she would mingle with some of the richest of the rich, the royalty, etc. in Europe. One day she was laying out and decided to sun herself on the Riviera, and then went out to one of the parties that night in a white outfit with her tan, and that suddenly became the fascination and became one of the things to do. Now, I just wanted to help you to understand how that contrasts. Most individuals who had a tan around that time were considered merely ditch diggers. They were the menial, lower society folks who worked outside. So tanning was not considered especially a society status symbol or something of attraction until what Coco Chanel did. If you talk to a modern dermatologist, they'll say to you that tanning is more a means in which the body is responding to radiation exposure, particularly ultraviolet light. And it tends to accelerate the aging of the skin. I had years ago this fascinating picture on the front cover of an issue of Science News. I'd say like 1980 or something like that. And there were two individuals. One was a Hopi Indian. And if you looked at her, she was very, very wrinkled, had deep, deep furrows of wrinkle spaces, almost looked like cracked mud for her face. Okay. Then you had a Buddhist monk. Now, the Buddhist monk shaved, smooth skin all over him. And the journal asked the question, which of these is older? The answer was the Buddhist monk, because the Buddhist monk was always in shelter in the monastery, never exposed to sunlight. The Hopi Indian in the Southwest was always exposed to sunlight, so her skin had aged over that period of time. The Hopi Indian was only 64, the Buddhist monk was 89, and so you can see the contrast there. Here you see the melanocytes in the striatum basilae, and you can see how they're making the granules and will export these melanosomes to other cells, including the keratinocytes that make up the skin. Some of the keratinocytes would also have concentrations of keratin present, which would account also for skin pigmentation. Okay, and we move forward. There are other means to affect skin color. Hemoglobin, yep, blood. Remember that you're going to have several plexi there of blood vessels. The subpapillary plexi is a blood supply in the deeper dermis that supplies blood to capillaries in the papillary layer. If blood vessels are dilated, the skin becomes more flushed, more reddish. When blood supply to the skin is temporarily reduced, let's say in a situation of hemorrhage or something else, the skin is going to appear pale. This can also happen if the blood supply is reduced because of reduction in blood pressure or pumping of volume from the heart. Now, if you have sustained reduction of blood flow, the blood will release the oxygen, it'll appear darker, skin will become darker. And then we have the phenomenon called cyanosis. It has nothing to do with cyanide. It's that bluish tint due to the low oxygen that you see of the blood. You can easily see this in fingernails or lips, even if you have patients of color. That's where we get into using the pulse oximeters that they put and attach right to your finger on the nail side, because right underneath the nail is a capillary bed. And so the pulse oximeter detects by using a near red color beam, which will bounce off and tell the amount of oxygen concentration in the blood. Okay, moving on. Here is the hair shaft. Here is where we have all this pigmentation here. Now, some of the melanocytes will be in the bottom of this hair follicle and will account for pigmentations in the hair shaft itself. But I wanted to bring to your attention both the cutaneous plexus and the subpapillary plexus, because it is both of these that play a role in the skin color. Want some more? Well, let's talk about skin color from the perspective of some of the other phenomena that we see. What if it's redness? It could be fever, it could be blushing, it could be also polycythemia. But poly means many. Cythemia is cells. This is an unusual phenomenon that occurs with some individuals. Sometimes they will use blood doping, where they will increase the amount of blood cells, red blood cells, for athletes that are in competitive athletic events. Pallor or blanching can also be a sign of anemia, as I said, low blood pressure, fear, or anger. Jaundice, now this is something that you'll see. It picks up the bile pigments, and you have a yellowing. You'll see it in the sclera of the eye, the white of the eye, as well as into some of the skin, and this is due to a malfunction in the liver. And so the bile pigments back up and remain in the blood and eventually deposit themselves into the skin or the sclera of the eye. Black and blue marks, those usually are bruises. That's subcutaneous injuries in blood vessels, bruising, damage to the blood vessels. And then we have bronzing. Bronzing is a unique phenomenon that you see with Addison's disease. It's a hypofunction of the adrenal gland. Now, before I show you the next set of pictures, I want you to be aware of how. We have a pituitary hormone called ACTH. ACTH is the hormonal signal that tells the adrenal gland produce certain components like cortisol and corticosterone. But if the adrenal gland, for some reason or another, is not producing that, you get this massive production of ACTH in an attempt to stimulate. But at the same time, because you're making so much of ACTH, you'll also end up making a larger amount of another hormone called MSH, melanocyte stimulating hormone. Yes, that is what's going to cause a hyperproduction of the melanocytes, which will account for skin bronzing. These are two candidates, or these are two examples of those who have had Addison's disease. One, you know, was a famous president, John Kennedy, and the other is this lady. And if you notice that her skin is somewhat filled with freckles and it's also kind of on the darker side, Kennedy ended up with some bronzing because these both are cases of Addison's disease. Now, in the next situation, I'm going to talk about argyria. This is a condition caused by the improper exposure or consumption of silver compounds, silver metal, or silver ions. The symptoms, the skin becomes bluish or blue-gray colored. The coloring may also include the eyes and the sclera and the cornea, and this is called argiosis. Now, where do you get this? This is because there's been this phenomenon, this fad, whatever you want to say, it's pseudoscience, equivalent to snake oil, where people will say, Consume colloidal silver and you will not get sick with X, Y, Z. Even in the outbreak of more recently COVID, there were still those trying to sell colloidal silver solutions or how to make it. Even when they were chastised and banned from using it or selling it or claiming certain things by the Food and Drug Administration as well as the Federal Trade Commission, people still basically would sell how to generate silver ions in your water, but wouldn't say what it was for. It's almost to say, wink, wink, you know what to do with this. Unfortunately, we have these cases. Now, I assure you, these are not photoshopped. Yes, this man has white beard. He actually has a bluish-gray skin. It's not Papa Smurf. No, this is someone who has consumed a certain amount of colloidal silver. The silver ions bind to the sulfur and to the selenium that are in certain amino acids, and so they stay deposited there and will not leave. This gentleman has argiosis, as you can see in the eyes, this bluish-grayish tinting there. This is a young lady who at age 15, you can see her natural color. This is Rosemary. And after Rosemary spent years consuming colloidal silver, this is her present skin. There actually was somebody that ran for, I think it was state rep in Colorado or Wyoming, one of those states. And basically, he was pretty much a bluish-gray person in his skin and had no problem with it. Now, if you see the central area, this is an actual ad I picked up off the internet. It's still out there. And you can tell that it's sort of pseudoscience because if you look at all the things it does, both internal, external affections, etc., when you start seeing this, you have to raise the red light because, you kind of say, well, wait a minute, you're going through all of these ailments which are bacterial, viral, flu, there are various types of viruses and all sorts of other things. Then you have to start wondering if this is more just phoniness and a fraud. And you, the listener, may be involved in allied health somewhere, and you're going to be dealing with some of this and have to have an intelligent response to patients that may claim to use this. Now, let's talk about skin cancer for a few minutes. There are several different types. One type best known is basal cell carcinoma that starts at the basal cells, at the striatum and basilae. There's a very high survival rate if it's treated early. Squamous cell cancer, or carcinoma, starts and develops in the squamous cells that make up the middle and outer layers of the skin. It is slow growing. It'll appear like an open sore. And then we have melanoma, which starts in the melanocytes. This is very dangerous because it can become malignant and can spread throughout the lymphatic system. This is usually the type that can lead to a lot of death. It's also hard to detect sometimes because it'll show up on skin where you wouldn't normally think of melanoma being there. For example, between toes, on the backside, and other places. So when someone is under review for melanoma or for any type of skin carcinoma, they really have to be checked from all over, top, bottom, through the hair, everything. Here is an example of a basal cell carcinoma. It's very common to see these on the nose because the nose is one of the areas that's most often exposed to the sunlight. As you can see here, you have the squamous cell carcinoma here. It looks like an open sore. And finally, you see here melanoma. Notice the multiple colors here on the melanoma and the size. And you can see here, if this is centimeters, you're talking about something that is probably, let's see, 1, 2, almost about 2.5 in size. Also, it has an irregular border. That's what I'm bringing up because there is an A, B, C, D, and E of skin cancer. And if you have certain these particular aspects, this is where you really should be getting checked by a dermatologist. If it's asymmetrical, meaning that the molar spot has an irregular shape, and if you look at it bisected, the two parts don't look the same. They look very different. Next question, border. Is the border irregular or jagged? If it's yes, then somewhat necessary to have that examined. Is the color uneven, or do you have multiple colors? So in other words, you can have black, brown, red, tan. You can have sort of a purplish color. If you have multiple colors, it's hinting that there's multiple types of cells showing up and growing. Diameter, is the molar spot larger than the size of a pea? And then evolving. That's the E part. Is it elevated? If it's basically raised up above the level of where the skin is, or if it's changed a lot in the past few months, then it does require being looked at for the possibility that it is skin cancer. Early detection is usually the key in the treatment of this. Let's also talk about the subcutaneous layer for a few minutes. This connects the dermis to the underlying tissues. The dermis layer, we have to remember, is composed of the papillary layer, and you have dermal papillae there, and they basically diffuse nutrients, as I talked to you before, to the striatum basally. The other thing about the dermis layer is that it's loaded with lymphatic vessels and sensory nerve fibers. It is composed of vascularized areolar tissue. When we get to the reticular layer, this is a meshwork of dense, irregular connective tissue, as I've mentioned before in a previous chapter. Collagen fibers are going to extend in all directions, and they will extend into the subcutaneous layer. The reticular layer is going to be loaded with sweat glands, hair follicles, nerve fibers, blood vessels, and lymphatic vessels, as you can see here. Notice the reticular layer, and you can see where all the fibers are in all the different directions to provide strength and recoil. The papillary layer here, you can see somewhat the structure and also the high vascularization here. Okay. Then we get to this lower layer here, and you're going to see basically the reticular layer of the dermis. This is another image. But then when you get into the subcutaneous level, okay, this is the hypodermis. You're going to see adipocytes as well as, in some cases, areolar tissue. In many cases, depending on what journal you're reading or what textbook, the subcutaneous layer is not considered part of the skin. The layer stabilizes the skin's position relative to the underlying skin. This is dominated by adipocytes. You will find that there are capillaries, but they're sparse. The subcutaneous layer is one of the common sites for subcutaneous injections with hypodermic needles. Here again are the adipocytes. This is a scanning electron micrograph, magnification 250. And you can see some of the fibers around it, but also predominantly adipocytes. Remember, adipocytes are important to provide for insulation and retention of heat where necessary. The touch receptors in the skin, you're going to have a variety of them. Free nerve endings, which are sensitive to touch and pressure, they're located between the epidermal cells. Tactile discs basically detect sensations of texture and steady pressure. They're located deep in the deepest layers of the epidermis. Meissner corpuscles, or tactile corpuscles as they're called, detect delicate touch, vibration, and pressure. They're located in the papillary layer of the dermis. The lamellar, otherwise known as Pacinian corpuscles, these are sensitive to deep pressure and vibration and located in the dermal layers and subcutaneous layers. And then we finally have the Ruffini corpuscles. These are kind of bulbous looking in appearance. They're sensitive to pressure or stretching of the skin, and you would find them in the reticular layer of the dermis. So you can see how these are all arranged here, from free nerve endings, tactile discs, Meissner corpuscles, Pacinian corpuscles, and the bulbous ones. It's interesting to note that a lot of these are just like raw nerve endings, but then with structures built around them for the purpose of being able to sense certain frequencies of vibration or pressure, and yet they're immune to all the other types. Now, with some structures that we're going to see that occur in skin, tension lines. These are formed by collagen and elastic fibers oriented in skin to resist forces normally applied to skin. Surgeons learn about these because they can cut parallel to the lines to enhance recovery and minimize scarring. It's when you cut across all the lines that the injury takes longer and has a greater chance of forming scarring tissue to just hold it together. And if we take a look, here are the tension lines. So you can see how these patterns occur. Now this, of course, is the posterior view. This is, of course, the anterior view. And these tension lines seem to build over some of the musculature. So what you want to have is, if you're going to make a cut, you're going to follow the tension line here to make it easier to sew or suture together these areas. If you were to slice downward, it becomes much harder to have full, complete healing because you have the different tensions separating them. And so more often, if you have an injury such as back like this, where the line, I'm having the pointer go up and down, you're going to have a greater chance of scarring there. Now, we have some other unusual skin markings that you're going to see. We've talked a little bit about dermal ridges. Epidermal ridges, they're dermal ridges really in the thick skin. Tension lines, we've talked about, they're formed from separations of reticular bundle regions. We mentioned about their importance in surgery. Flexure lines, these are interesting. Take your hand, palm up, and curl your hand inward, the fingers. You will see these nice little lines which allow for joint movement. Without the flexure lines, it would be much harder to contract your fingers in rolling them forward. And you can see this here. Of course, we talked about the openings of the sweat glands and the friction ridges, etc., the fingerprints, the tension lines I've shown you, the flexure lines. And you can see the person has begun to flex their thumb, and there is the tissue that goes inward to allow for the spacing of the joint. Now, the next couple of areas I want to cover are dermal tears, striae, which are also known as stretch marks, and blisters. When you take a look at basically this concept of dermal tears, this has been an enhanced stretching that has occurred, and literally you get what form these kind of gray-white or silvery or whitish lines, and this is because of an overstretching and then later on a subsequent reduction. You see this with pregnant women, particularly late in the pregnancy. You'll also see this with individuals who have had morbid obesity, and then they've gone through some type of modification that has caused a great weight reduction. And you can see where the stretch lines are right through here, or in the female right through here. Literally, some of these are cases of the dermis being stretched out so much that you have minor tears. Blister is when you've had pressure put upon it, in this case, not due to heat, but due to just tremendous amounts of forces between the epidermis and the dermis, which leads to a small separation and a buildup of fluid between the epidermal top, the top part of the blister, and the lower levels. Now, go back to 1950, they would always talk about, well, you got a blister, whether it's because of a burn or whether it's because of friction, you pop it. Nowadays, they don't. What they do say is you would have to empty the blister if it becomes white, if it's bleeding. White usually indicates that there's an infection inside, so you want to remove the infectious material. But if not, you just basically let it sit there, the fluid will be reabsorbed, and eventually the blister, the damaged skin will be sloughed off. Now, we talked about tension lines formed by collagen, elastic fibers oriented in skin to resist forces normally applied to skin. We've talked about this repeatedly about this. Now, I'm going to move into burns now. Now, burns you have to understand. If we were in a lab, there's a nice model here. It shows on one side the different layers of the skin: epidermis, dermis, hypodermis. Okay? Burns are extremely important for us to understand. First degree burn, you're going to see some redness, erythema, which is kind of a reddening, and partial epidermal damage. It's uncomfortable, but basically this will recover. Okay? Second degree burns. This is where you're going to get blistering, swelling, you're going to get pain. The entire epidermis is affected, and you have partial dermal damage. The infection risk is greater if the blisters are ruptured. That's why they don't do automatic rupturing of the blisters anymore, only if there's evidence of infection. Okay? If it's just a bump and it's clear fluid and it doesn't seem to be any bleeding or anything, you let it be. That's first degree, second degree. Now we're going to get into the really sad one, third degree. Third degree, you have full thickness burn. Epidermis, dermis, and you may even extend into the hypodermis. The interesting thing is, after just the burn has occurred, sensory nerves are destroyed, so you have very little pain. But if you look at the tissue, it's either cherry red, white, gray, or black. Granulation tissue can't form. Epidermal cells are unable to recover because what you've literally done is destroy all of this tissue. You have to remove it. This is called debridement. Usually what happens right after third degree burn, the big threat is loss of fluid. Within 24 hours, the next big threat is infection. Because what you have to think about is, you've now taken all this proteinaceous material, yes, okay, the epidermis, the dermis, etc., and you've destroyed it. You destroyed any immune protection. You may have denatured the proteins that are in all of this tissue. You've got fluid. And so for bacteria and fungi, this is a party. It is a smorgasbord. That's why they have to start removing the burnt tissue as quickly as possible. And they will usually use a surface antibiotic like silver sulfdiazine to cover over the areas and then try to work out grafting. Okay? Here's an example of a first degree burn. You see the reddened finger area. Here's an area of the second degree where there's a blistering right throughout that whole area. Okay? But these are all considered partial thickness burns. This is a burn that's third degree. As you notice, you've gotten right down below into the hypodermis, into the fascia. You'll notice that there's a little bit left that they haven't completely debrided off, and so it's blackened right here. And this looks like what would appear to be a heel, foot, etc. They have to graft something here, because if you don't, the response would be basically a distorted scar tissue called a keloid forming around here. Okay? This is considered full thickness burn. And I'm just going to reiterate some of these points because they're really important when we deal with burns. Third degree, initial response, prevent infection, and response to fluid loss. But here's some of the other important things. Because you have lost so much proteins and materials, the caloric needs of a third degree burn patient are going to be very high. This is due to the loss of the protein, the tissue, the fluid, and electrolytes. Skin grafting will be necessary. You'll have also what is referred to as a split graft. This is where they take partly some of the dermis, but they also take some of the full epidermis, because the epidermis has already been annihilated, so basically destroyed. You've got to get that to begin to grow also. Full thickness graft is when you take the full epidermis and both parts of the dermis, so reticular and papillary. Now, autograft. This is a graft that you take from yourself, so you have no real big worry about rejection. There have been some attempts at cell culture of skin. There is, I believe, the University of Pittsburgh. They've done some amazing work where they can take a postage stamp sized piece of skin and culture it up to make these big sheets and then put them onto the patient. But that's at that facility. It's not like you can basically go down to Five and Dime and get it done. And there's special burn centers that just handle this. There's also an allograft, which is grafting tissue from frozen skin from a cadaver. And then xenograft. This is grafting skin from an animal. This was a big research effort, particularly in the 60s and 70s, but the problem that everybody dealt with was tissue rejection. And usually, allografts and xenografts are temporary, as immune rejection occurs within 7 to 21 days. Now, skin functions affected by burns, that's fluid and electrolyte balance, thermoregulation. We have to protect from infection, okay? As I mentioned to you before, you're going to have to prevent infection. Sometimes what happens is because you've got to replace lots of the lost tissue, the proteins, the electrolytes, the fluids. A lot of times it's not just feeding them by mouth. It's going to actually be parenteral. You're going to have IVs. You're going to have a lot of ways to get as much of the calories needed, okay? As well as topical antibiotics, intravenous antibiotics. One of the other things to note is that if the individual has the burn go into the mouth, into the nasal area, or even into the upper respiratory tract, you face the possibility that someone may die because the tissue that has the plasma from the fire, in other words, the literal flames, get into that area, that will swell up and it may be destroyed or damaged in such a way to block respiration. Okay, but when you have a patient that has been burned, how do you report this? Well, there's a simple method of estimating the percentage of surface area affected by burns. This takes into consideration both front and back of body parts. You will note, as I show you in the next chart, this is the rule of nines, but it differs between adult and child in body mass. Also, as I mentioned to you before, burns involving the flame, the actual hot plasma, may include mouth, throat, respiratory area, and the damage can include swelling of these tissues and blockage of respiratory function. So, most people can survive a third-degree burn affecting 70% of their body. Very few can survive a third-degree burn affecting 50% of the body. If the area exposed is down to 20%, most people can be saved, although elderly people, infants, may fail to survive a 15% skin loss. So that's kind of sad. Today, it's possible for someone to survive a body burned up to 90% if they are a healthy adult at the beginning. Here is the rules of 9. Okay, so if you were to take the front part of the body, that would be 4.5%. You take the back part, that's 4.5%. The total of the head is 9%. Upper limb, 9% each. Now, what they mean by that is 4.5 in the front, 4.5 in the bottom, in the back. Same thing with the trunk. It would be 18% on the front, 18% on the back. Lower limb, 18% each. So that would be 9% on the front, 9% on the back. That's what you have to keep in mind. If you look, though, at a child, because of the lower mass of the body, the lower limbs are 17% each, genitalia 1%, upper limb 9% each, trunk 32%, head is 15%. Okay? Now, after we've gone through all of this, we need to go through some of the accessory structures of the skin. The structures originate from the epidermis during embryonic development. In other words, epidermal derivatives. That's what these are. These include hair follicles, exocrine glands, okay? Hair follicles produce hairs that protect the skull. They produce hairs that provide delicate touch sensations on general body surface. When we talk about exocrine glands, we're talking about the sweat glands. Remember that these assist in thermal regulation. When we sweat, it's not just the making of the sweat, it is the evaporation of that sweat that really cools the body. Sweat also is a means to excrete some wastes. And then we also have to deal with the other exocrine glands, which are the sebaceous glands. They help lubricate the epidermis, so they're going to produce the oil part. Nails protect and support the tips of the fingers and the toes. As you see here with the integumentary system, the accessory structures include hair follicles, exocrine glands, and nails. Okay, so let's go through them. First off, hair follicle is a complex structure consisting of epithelial and connective tissues. Now this consists of basically the hair shaft, heads up, hair shaft. All that hair, you hear it in your commercials, feed your hair and all this other stuff. Hair is dead cells, okay, except around the root hair plexus. And we have a hair root. Now we have two different designations for hairs. Terminal hairs, these are the large coarse ones found. They're often pigmented, located on the scalp and the armpits. And then vellus hairs, these are smaller, shorter, more delicate, located throughout the general body surface. One little pointer. You don't see vellus hairs as much. If you see a lot more of it in someone who is very low in body weight, that may be an indication of anorexia nervosa. As someone's starving themselves, there is a response that occurs and they start producing more vellus hairs. And that may be because the body is attempting to still do thermal regulation, because the normal thermal regulatory mechanisms are failing because of loss of adipose tissue and much more difficulty in thermal regulation of the body temperature as a whole. Here is the hair shaft. Here is the sebaceous gland, which produces some oils to allow the hair to be somewhat lubricated. Here's the hair root. We go all the way down to the root hair plexus. Here's our erector pili, which is a smooth muscle structure. It will get activated, particularly under sympathetic nervous stimulation. The outer layers are a connective tissue sheath, or sort of a protection there. And of course, you've got also right down here, both blood supply, which will form into sort of a little capillary tuft inside here, as well as nerve fibers. So let's take a look at these nerve fibers here and the hair papillae. It is right in this little area here, this structure, that you're producing cells that will basically make more of the hair matrix and the hair structure. You also have melanocytes that will produce various pigmentations to the hair, okay? But everything from here up are all dead cells. The hair structure is consisting of the medulla, the cortex, and the cuticle outer structure. The hair follicle structure consists of both an internal root sheath, an external root sheath, the glassy membrane, and the connective tissue sheath. So this is if you've taken a cut right here, as you can see this, okay? Now, let me go through some terminologies to help reinforce this. The hair bulb is the base of the hair follicle. The cuticle, this is the thin, tough, hard, composed of thin, tough, hard keratin. The cortex has thick layers and it's composed also of hard keratin. The medulla is the core, and it's flexible and contains a soft type of keratin. The hair matrix, this is a layer of basal cells actively dividing. The daughter cells are pushed upward. The hair papillae, PEG, is really a small connective tissue with nerves and blood vessels. Pull out a hair, bang, you feel it. That's because what you've done is separate the hair from the papillae, and the nerves are activated. And I've talked about the erector pili muscles. They're just a bundle of smooth muscle cells attached to the hair follicle. When they contract, they tend to cause the hair shaft to move straight up, and you'll see this little bump-like structure on the surface of the skin. Those are called goosebumps. Okay? If you've seen animals, now humans don't do this as much, because the interesting thing is that when our hairs stand up, they do right at the level of the skin provide a little bit more of a insulation there. But for animals, it's more an emotional response. I've got two dogs. When I see the hairs stand up along the entire spinal column, it's not a good day. That dog's going to get into a fight or they perceive a threat. And so what you have to do is note these structures and how they cause them to do what they do. Okay? How about hair growth? Well, it's interesting. We have this cycle that occurs. The active phase, you have continuous hair growth. Okay? And then you have sort of this resting stage where the hair loses its attachment to the follicle and it becomes what they call club hair. You get the regression and the transition. You get a resting stage. Notice that the hair shaft gets detached, and then you have the follicle reactivation and growth of replacement hair. Okay? Once you shed the club hair, the hair matrix produces replacement hair. Now, let's talk about sebaceous and sweat glands. Sebaceous glands produce an oily secretion into the hair follicle by holocrine secretion. If you remember that from last chapter, that's literally where the cell breaks up. The cytoplasm comes out with a bunch of the vesicles that contain the sebum. What is sebum? That's a mixture of triglycerides, cholesterol, proteins, and electrolytes. Basically, it's keeping the hair from becoming brittle, moisturizes the surrounding skin, and inhibits bacteria growth because there actually are some proteins that are antibacterial. Sweat glands, though, are a little bit different. They're either apocrine or eccrine. Another way to say eccrine would be merocrine. And if you remember, what we're talking about there is the exocytotic release is either in vesicles or with a chopping off a part of the cell that contains a collection of these vesicles. And here you see the typical sebaceous gland. The sebaceous gland can be directly attached to the hair shaft, which you can see here. But a sebaceous follicle secretes sebum on the skin surface. And you notice how the arrangement is. It's much more complex. Okay? With sweat glands, you have this myoepithelial cells. These are contractile cells. That's what the myo hints at. And they squeeze the gland for secretion. Apocrine are located in the armpits, otherwise known as the axilla, around nipples, the pubic region, and they secrete into the hair follicles. They produce a sticky, cloudy, potentially odorous secretion. They do a merocrine secretion under hormonal control. These include the ceruminous glands, which are in the ear canal, and the Marais glands, which produce milk. When we talk about the eccrine sweat glands, which are also called merocrine, they discharge secretions directly onto the surface of the skin. Now, this is where you get more watery secretion that will contain electrolytes. It also is a merocrine secretion. It is controlled by the nervous system. The palms and soles have the highest concentration of these glands. It's important in thermal regulation and in excretion. And as I mentioned before, there is in sweat, as well as the oil, some antibacterial action that occurs in these compounds. Here you can see the apocrine sweat glands here. They have the lumen. So basically you're having all of these glands secreting into the lumen, and it will be then transported by the myoepithelial cells, kind of squeeze everything moving. The eccrine gland cells here have some myoepithelial cells here. They're just lower in the arrangement, but you still have them. Okay. Let's talk about nails. My gosh, it sounds like a beauty salon. Well, I'm just being humorous there. Nails are really thick sheets of keratinized epidermal cells that protect the tips of the fingers and toes. So you're going to note the structure of the nail body, the lateral nail fold, the lateral nail groove, the lanuna, the eponychium, which is also referred to as the cuticle, and the hyponychium, and the nail root. So here you can see, here's the eponychium here. The lanuna is this white patch here that's sort of at the edge of the proximal nail fold and the epinichium. Underneath here, you have these blood vessels. They give the nail the characteristic kind of pinkish color. Here is the free edge of the nail body and its direction of growth. If you look at this at a cross section, of course, here you're going to have the phalanx, the bone. Then you're going to have the dermis and the epidermis. But underneath this, or I should say covering over this, you have the nail root, the proximal nail fold, okay, the epinichium, which we call the cuticle, the luna, which would be right here, the nail body, and then of course we have this little spacing here of tissue called the hyponichium, so below the nichium. Okay. Now, nails can give you a lot of information. Yeah, of medical signs, of nutrition, of metabolism, of what medications the individual, they may be visible signs of disorder. Psoriasis, that's a rapid cell division of the striatum basilae. You're going to have a concave nail, that's cholionichium, and that's where the blood oxygen, you have blood oxygen disorders or hemochromatosis. Wilson's disease, you would have a buildup around the luna of kind of a greenish pigmentation, and that would be evidence of a buildup of copper in the system. You can have also a yellowed stained nails. This is due to smoking, the nicotine deposits and the smoke deposits, because where the person's holding the cigarette. The other thing that you can get is a clubbing of the fingers, and the sort of right around it, it's kind of like a little widened. And this is because of poor blood circulation, some of it brought on by smoking, some of it as an early warning of onset of heart disease. Okay. Now, age-related changes to the integument. Over the decades, they've tried to find ways to help people, enhance them, look for the fountain of eternal youth and all this other stuff. Well, first, what you have to figure out is what are the changes that are occurring in the integument. So let's take a look at this. First, you're going to notice that there are going to be fewer melanocytes. So the skin is going to have a slightly lightened pigmentation than they were when they were younger. They'll have a drier epidermis, a thinning epidermis. As a result, also, they will have a diminished immune response. The dermis itself will be thinned. They will also have decreased perspiration, a reduced blood supply. Also, as a result of this, now think about this, diminished immune response, thinning dermis, reduced blood supply means that you're going to have a slower skin repair if you have injuries. You'll have also fewer active follicles, so the hair produced in that area of the tissue is going to be diminished. You will also have altered hair and fat distribution. There were some studies done in the 1990s where they were trying to look at what if we gave replacement testosterone to octogenarians, so in other words, somebody who's 80 or older, to replace some of the, and help them to have a better quality of health. One of the key things that they also did was also start giving human growth hormone. And one of the interesting things they found was, well, they seemed to have a greater muscle mass, their skin became thicker, and they had less injuries, they had a quicker repair of injuries, and but the study stopped because of fears of having some adverse effects that can be brought on by extended use of growth hormone or extended use of testosterone. But these are the changes that you need to be aware of that do occur. Now, what about responses to hormones and ultraviolet light? Keep in mind that the integument is tied to other body systems, physically and functionally. The cells will respond to the following hormones: glucocorticoids, thyroid hormones, sex hormones, growth hormones, and growth factors. This is particularly where we get into one type called epidermal growth factor, EGF. These will enhance the capability of growth, etc., Glucocorticoids do reduce the tissue when it's undergoing stress. Of course, sex hormones play a role. For a while in the 80s going into the 90s, there were some women that were postmenopausal, and they would start taking literally birth control pills. They wanted estrogen replacement therapy. And for a while, doctors were signing off on this because the women reported that their skin was much better in shape and their nails were in better shape and they felt better. The problem was that by the late 1990s, going into about 2000, the FDA banned hormone replacement therapy because the risks outweighed the benefits. What I mean by that is by giving women that were 50s and 60s the estrogens. Estrogens, any steroidal hormone, can act like gasoline on a fire. It can cause the growth of tumors to grow much faster. And so the fears were that if you provided these women with estrogen, etc., that would enhance their risks of breast and reproductive, like ovarian and uterine cancer. So these situations were eliminated as a therapeutic. So what do glucocorticoids do? They loosen the connections between keratinocytes and reduce the effectiveness of the epidermis as a barrier to infection. Growth hormone stimulates fibroblast activity and collagen synthesis. Thyroid hormones maintain normal blood flow to the subpapillary plexus. Here we are. Sex hormones stimulate the epidermal cell divisions, increasing epidermal thickness and accelerating wound repair. Growth hormones, growth factors, are compounds produced by the body that stimulate cell growth and cell division. So we're looking right here. Okay, mitosis. And EGF plays a role. It promotes basal cell division at the basal, the striatum basale, striatum spinosum, accelerates keratin production of maturing keratinocytes, stimulates epidermal development and epidermal repair after injury, and stimulates synthetic activity and secretion by epithelial glands. Okay. What's also important about the integument? How about vitamin D production? What happens is vitamin D is extremely important, and a limited exposure to sunlight, ultraviolet light particularly, plays a key role in vitamin D3 cholecalciferol synthesis. Now with sunlight, that works out nice. Epidermal cells in the striatum spinosum and the striatum basale convert cholesterol-related steroids to cholecalciferol. You can get some of this in diet too. As a matter of fact, in this country, that's where we take and fortify certain foods, particularly dairy products. Okay. Now, some fish-related products also have cholecalciferol. If you remember talking to a relative who talked about cod liver oil. Cod liver oil had a lot of some of these products, and it enhanced vitamin D levels and enhanced health. Well, are there other means? I'm going to show you one in a second. What's the purpose of all this vitamin D3? Because it helps to avoid rickets. Rickets is the softening and flexible enhancement of long bones. This is due to poor intake of vitamin D3 and results in poor bone calcification. Now, the problem is, in the later 90s, we started seeing a resurgence of rickets, and everybody went, wait a minute. This is the United States of America. We shouldn't be having this. Well, it's not because we're not getting enough sunlight, although some cases that is it. Kids are spending way too much time in the house, not being exposed to sunlight, not playing like they used to in the 50s, 60s, and 70s. But also their diets were absolutely abysmal. And it was very recognizable that in some cases they were not eating stuff that was even fortified with vitamin D3. Now you have to understand what fortification means. D3 in just milk enhances the absorption of the calcium in the milk and thereby helps build up the bones. Well, what if you don't have fortified milk? And what if you have a place where you don't get as much sunlight? What do? Well, I'll show you. First, keep in mind that sources of vitamin D3, sunlight, cholecalciferol, eventually makes calcitriol, and this is the stimulation of calcium and phosphate ion absorption in the digestive tract. In food, if you have it as a dietary product, same thing. What you see here is Siberian children getting a UV lamp. Now notice that all of them are right down to their skivvies, and they all have what is referred to as welder's goggles. These basically protect the eyesight while this lamp is producing a significant amount of ultraviolet light. This will enhance the children's own synthesis of cholecalciferol. I remember seeing this in the 80s. I've seen other photos. You can find them on the internet. You see out in Siberia, in Russia, they don't have fortified milk. They don't have fortified anything. And also in Siberia, it's well known, it's cold. And so they're all bundled up. And because they're bundled up, their skin doesn't get exposed to sunlight, to ultraviolet light, to any significant degree, and to keep them from having softening bones and rickets, etc. This is a public health measure that they all get. And these are all little kids, kindergarten, first grade, stuff like that. This is the effect of rickets. As you can see, this bowing down. Now, why are the legs bowing? Because of the body mass, the body weight is pushing down on the bone structure. And so these soften based on the forces from the body weight, and they can't maintain normal structure. And they can't hold up the weight. I'm just going to take some time for integument repair. There are 4 phases of skin regeneration. First, the inflammation phase, which is after the injury, mast cells trigger inflammation, the inflammation response, bleeding occurs at the site. The migration phase is then the next stage where a blood clot, a scab, forms to stop the bleeding. This is the accumulation of platelets and also fibrin fibers, and it prevents further infection. The macrophages come in, patrol the debris, patrol the dermis, and phagocytize debris and pathogens. The striatum basally cells begin to actively divide and migrate to the damaged site. The granulation tissue, this is the beginning of the actual formation of new tissue. This is basically a small capillary network, a little pinkish tissue, and this is new endothelial cells forming with fibroblasts, and the blood clot will form. The next phase is the proliferation phase, where the clot dissolves. The fibroblasts produce collagen fibers and ground substance. Now, high collagen fibers and low large blood vessels in the dermis will impede complete repair to the original structure. That's where we get into the scarring phase. Now, after weeks, the scar is dissolved and the epidermis returns. Severely damaged hair follicles, sweat glands, etc. are replaced by fibrous tissue. Inflexible and fibrous and non-cellular scar completes the replacement in some situations. Where the tissue cannot come together, you get filling up into it more fibrous tissue. Okay? Now, this can happen even internally. One of the examples I give is when John Paul II was stabbed in 1981 in the assassination attempt. One of the things that happened was that they pierced his intestine, one of the knife injuries. And so the doctors, after they initially stopped the bleeding, etc., noted he had discomfort, and they found out that basically the lumen in the large intestine had started forming these, what they call adhesions, or formations of fibrous tissue. They had to basically go back in, give him an ostium for a short period of time. That's basically osteo bag. So the emptying out of the large intestine. They clipped away the adhesion, and then they resected up the bowel after a period of time of healing. Keloids, these are raised, thickened masses of scar tissue that begins at the site of the injury and grows into the surrounding dermis. You see this particularly in certain extreme situations of burns as well. So we have the inflammatory phase, as you can see here from this diagram. Mast cells are going to trigger the inflammatory response. The bleeding is going to occur at the site. Notice that you've cut through the epidermis and the dermis. You have the formation of a scab, which is clotted up blood, etc. You're going to have patrolling macrophages remove debris and pathogens. You have the beginning down here, the formation of granulation tissue. You are undergoing rapid cell division and migration along the wound edges to replace missing cells. As this continues, you start having more fibroblasts building these deeper areas of collagen fibers. The deeper portions of the clot dissolve. Usually what you want to do is have the wound heal from the inside outward. The fibroblasts will produce new collagen fibers and ground substance. Eventually you have scar tissue forming. As time goes on, if the wound is not too deep and enough time has been allowed, the tissue will begin to build up here and replace the scar tissue. Well, that's about it for this chapter. I want you to peruse the chapter review on pages 205 to 206, complete review questions, pages 207 to 208, complete review sheets on 192 and 204. Remember that this is a review for your own knowledge of what you know and what you don't know. So take the time to review this stuff. If you have difficulty trying to answer a question, that means you need to look up the material, okay, in the chapter. The next chapter we're going to go through is chapter 6, which starts up with bones and bone structure. And we will see you very soon. Have a wonderful evening.